All right, let's do injuries of the shoulder. First, we have humeral fractures, which there are three types: the proximal, distal, and distal. But in all of them share the same definition of a fracture, where a piece of the bone is cracked or broken. So for the proximal fracture, it's near the shoulder joint. So right here is for the proximal. It's where the ball of the most likely the ball of the humerus is broken, and this with this fracture, you see the rotator cuff usually damaged. Next is the disophial or mid shaft fractures, and thirdly, is the distal fracture, which is near the elbow, and this is more common in children and adults. And for the proximal and distal, you see surgery for this requirement, and for disophial, surgery can be included, but we also see sometimes not surgically. But what can cause it is an indirect blow to the humerus or a direct blow. For the indirect humerus, if you were to fall on your arm and it's outstretched where the elbow is locked, the owner can be forced into the distal humerus, causing the distal humerus fracture. Or if directly on the humerus bone, or get hit in either like a baseball or being in a car accident, the humerus can fracture as well. For signs and symptoms, we will of course have pain, swelling, symptoms, a deformity as well, nerve damage if the fracture hit any nerves in the arm. You have nerve damage where the can feel sensation in the arm, the upper arm, the lower arm, and if it's near a joint, like the proximal or the distal one, it can feel as the shoulder joint or the elbow joint or to dislocate. Treatment special tests to treat will be special test is the squeeze, the shrink test, tuning fork can let's go as well. Imaging can be X-ray, CT or CAT scan or MRI to see if how big the fracture is for MRI reasons. If the fracture is that great, it can also tear ligaments or muscle. For treatment wise, we have PT for non-operative immobilization to a splint. For operation standards, we have external fixation, open reduction, internal fixation, intermediary nailing, or total elbow arthroplasty. And this is what it looks like. As I said here, we have the proximal, the distal, and the distal, and each one has the location and the severity of each one. So for the proximal, we have extraarticular, partial articular, and complete articular. For distal, we have simple, wedge, and complex. And for distal, extraarticular, partial articular, and complete articular. And each one, you can think of it as a sprain. The greater of severity, the more how great the fracture is. So you can see this as ABC or grade 1, grade 2, or grade 3. Next, we have the clavicle fracture, which is something I have done in my life before. So the clavicle, aka the collarbone, is fractured as well, or broken into pieces, or have a hairline scratch, as fractures do. These are most common in adults, 2 to 5%, and children, 10 to 15%, and kind of represents 44 to 66% of all shoulder injuries. And for most people, it happened in childhood, like it has to me. And I usually fall on a lot of shoulders, most common in my life for a college fracture. For me, example, I ran into somebody with my bike. Then as I ran into, I flew and hit my clavicle right here on the lateral side. And obviously, as the student got to the hospital, it was going to be a fracture that didn't require surgery, which we will go into later in the video. But despite the force, besides the fall on the right shoulder, it also being more like any compression force on the clavicle can also cause a fracture. So fractures are classified in 3 groups depending on location. So the group 1 fracture is the middle 1/3 or the mid shaft. The group 2 is the distal or lateral fracture, which my fracture came under that category. And group 3 is fractured to the medial or proximal 1/3. So, for signs and symptoms, we can have cradling the injury where the person will hold the injury to make sure that if they remove it, the injury will get worse. So cradling means they're going to hold it and protect it. A snapping or cracking sound when the bone cracks. A step deformity, so it's depending on if you have it at the lateral 1/3 of the clavicle, you can feel like the clavicle will step down, like a big stair step. Also, it'll be swelling, abrasion, crepitus. For cellular test, imaging is the best way to see where the fracture is and how severe. So that could be radiography, CT, arteriograph, or ultrasonograph. For treatment, physical therapy, no matter if you're having surgery or non-surgery. For surgery, in cases we have internal fixation with plates and screws and intramedullary fixation. Or for non-operative, which is for my case, since my fracture wasn't great enough for a surgery, I just put sling immobilization. So just put a sling around your arm, and it stays, and you just immobilize for around 3 to 4 weeks as it heals. But if healing does not work properly, then surgery can be the next step. It doesn't look like as it can. We have the clavicle. We have the lateral, the middle, the proximal locations of where the fracture can look like, and to the right of it, we have the 3 most common ways a clavicle fracture starts. Where A, you either fall with an arm out onto your hand, or fall onto the shoulder, or have the right blow to the shoulder. Next, we have the sternoclavicular sprain, which is any sprain is overstretching of the SC ligaments. So in this case, it's where the sternoclavicular ligaments is stretched or pulled beyond its means, causes to overstretch, which leads to a tear. This can be caused by trauma, overextension, and repeated stress. Like any sprains we have from before, it comes in 3 grades. At grade 1 is a sprain with a slight stretching of the ligaments, where this is still intact, but the fibers are still together, but the fibers are stretched to balance, means where it start to tear. So that's where you go into the grade 2, where when the ligament is stretched to its beyond means, you start to see the partial tearing of it. So once the partial tear once the ligaments keep stretching and stretching until it pops off or torn off, you get to grade 3, where there's complete rupture of the SC ligament. And with this ligament, SC ligament, it could cause, in some rare cases, it cause the SC joint to be torn as well. So for signs and symptoms, we have pain, swelling, range of motion, deformity, or a clicking and pop sensation. For special tests, we have the SC joint play test. We also, for imaging purposes, we have MRI, X-ray, and CT scan. For MRI, we're going to see which anterior or posterior ligament is being strained. For X-ray, if a sprain is at, where you can see if any the sternum or clavicle is fractured, and worse at CT scans. For treatment wise, we have PT. It doesn't matter if you're in operative or non-operative. PT will be an automatic thing you would do afterwards. But for operative, we have physiotherapy, also medication such as ibuprofen for grade 1s. For grade 2 and 3, we see more surgery in play to reconstruct the ligament to put it back together. And then go into PT. Obviously, there's be a much longer rehab rather than the Of course, what it looks like, as you can see here, this is indicating of a grade 3 SC sprain where the SC ligament is completely torn off. So in this case, you will have surgery to repair it, and then go into a rehab that can take between 6 to 8 weeks, maybe 12, depending on the severity of the sprain. Like I said, as well as how surgery goes and how the person reacts to rehab. And next is what we had last in the spine is neuropraxia, where this is where the brachial plexus nerves is stretched. So they create a tensile force, and of course with this, there's also as well as it can also be compressed. But in most cases, you see the brachial plexus being stretched, it's creating a tensile force. Okay, so with that, there's also the rupture, the neuroma, the neuritis, and avulsion. But in most cases, the most common case is the compression neuropraxia or the tensile neuropraxia. And the signs and symptoms is numbness or loose of feeling in the hand or arm, inability to control or move the shoulder, arm, wrist, or hands, burning or stinging, which is another name for neuropraxia, a burner or stinger, or severe or sudden pain within the shoulder or arm. Special test is the brachial plexus traction test. While it says traction, it can all well as test for compression due to what side it is. So if you had pain, say you were to do the brachial plexus traction test this way, if you were to feel pain on the tensile side or the well that's being stretched, that's we're gonna have the brachial plexus on this arm. But if you feel on this side, it's due to the compression of the brachial plexus. For treatments, we have non-surgical options, which is PT. Again, PT will be both for non-surgical and surgical, doesn't matter. Coronary cream injections and medications. For more severe cases, we have nerve repair, neuralgia, a nerve graft, or a nerve transfer. And going to the image, we see the brachial plexus in two ways. We see the first image, the first injury, where the brachial plexus is still intact, but it's slight thinning in the red circle area, meaning that the brachial plexus is stretched beyond its means and it's causing a tensile force. And the other two, where the brachial plexus is torn due to a rupture. Finally, we have bursitis, which is a painful swelling of the subacromial bursa sac caused when the bursa sac is damaged or irritated, which causes inflammation. Usually there's three types: a chronic, which is it builds up over time, or acute, usually can be a result of an injury and it's a one-time thing, but it can lead into chronic if it's not treated properly or treatment or immediate treatment is not working as well. And infectious, where an infection within the body spreads up to the acromial bursa sac and cause the bursa sac to be inflamed and infected. So signs and symptoms, as always, of course, pain in the shoulder, swelling, stiffness, reduced range of motion, point tender in the subacromial bursa sac. We have discoloration and heat and warmth. Special tests, Neers and Hawkins Candies. Even though they test for impingement, those impingement tests does test the subacromial bursa sac. So I believe those tests can detect any issues with the subacromial bursa sac, even if it's not impingement. You could see if there's any inflammation of it. As well as for imaging, there's X-ray and MRI. For a treatment standpoint, PT. For any injury, we always go to PT after surgery or non-surgery. For this case, we use surgery. For this case, we use non-surgery. Surgery is really not prone or for this injury, but if needed, arthroscopy can. But for the non-surgical aspects, we have physical therapy and NSAIDs, corticosteroids, antibiotics. What it looks like. So on the left, we see a normal, healthy bursa sac with no inflammation to it. And on the right, you see all the redness in it. That's the inflammation inside the subacromial bursa sac. And those are my works cited page. So there you go.